Think about the last time you broke a bone. Or maybe you had a really terrible chest infection.
Right, something distinctly physical.
Exactly. Usually when we talk about a medical diagnosis, there is this expectation of mechanical precision. It feels almost like engineering.
You expect a very clear answer.
Yeah, you break your arm, the x-ray shows that jagged white line on the film, and the doctor just points and says, well, there it is.
It's visible. It's completely objective.
But if you are stepping into the clinical reality of mental illness, you quickly realize you are entering a vast, uncharted, and often entirely invisible landscape.
Oh, absolutely. It's a completely different terrain.
Because you can't draw a vial of blood to measure a hallucination, you know? You can't put someone in an MRI scanner and take an x-ray of despair.
No, you can't. And that is the fundamental challenge of the entire specialty.
So if a patient's lived experience of mental illness is this subjective wilderness, how does a clinician actually map it?
Well, we have to build our own tools.
Right. And in psychiatry, rating scales are essentially the cartographer's toolkit. They are the compasses, the sextants, and the grid lines that we use to chart this territory.
I like that analogy.
They don't replace the landscape itself, obviously. I mean, a map is not the mountain, but they give clinicians a shared language to navigate it.
That shared language is vital. Because at its core, psychiatry is the study of how the brain, the mind, and human experience interact. And crucially, how that complex process can go wrong.
Yeah, and it goes wrong in so many different highly individualized ways.
Exactly. But to study that interaction, to treat it, and to actually know if our interventions are doing anything useful, we have to find a way to measure the invisible.
And measuring the invisible is exactly our mission for this deep dive. If you are a psychiatry trainee, a registrar, or just someone fascinated by how we quantify human consciousness, this one is really for you.
It's such a foundational topic.
We are going straight to the source material today. We're looking at Kaplan and Sadok's comprehensive textbook of psychiatry, specifically chapter 7.8, which tackles psychiatric rating scales.
It's a brilliant chapter, very dense, but brilliant.
Very dense, yeah. So we are going to unpack how psychiatrists transform subjective suffering into objective data. We will look under the hood at the statistical mechanisms of test creation, the psychometrics.
The maths behind the mind, essentially.
Right, the maths. We'll examine the actual tools used on the wards and in the clinics across different disorders. And most importantly, we are looking at how you integrate these numbers into clinical reasoning without losing sight of the human being behind the score.
Because that is the real danger, isn't it? Losing the human.
Well, that's exactly what I want to ask you about first. Before we even get into the weeds, I have to push back on the premise here.
Go on.
Doesn't attaching a number to someone's profound, debilitating grief or their terrifying paranoia risk reducing an incredibly complex personal story into a cold metric?
It's a very valid fear.
Aren't we creating a spurious sense of security by slapping a 7 out of 10 on something as profound as human consciousness?
The text actually explicitly warns about this exact trap. It uses the phrase, false certainty.
False certainty. That's a great term.
Yeah, because numbers look incredibly definitive when you write them down in a patient's chart. They look like hard science.
It look like blood test results.
Exactly. But the goal of these tools is never, ever to replace the clinical interview, nor to reduce the patient to a neat little data point.
So what is the primary goal then?
Standardization. We are trying to standardize information across time and across different observers. By establishing a baseline, we can see subtle patterns of disease progression.
Patterns that we might otherwise just miss.
Absolutely. We can catch subtle signs of treatment response that the naked eye, or just an unassisted clinical impression, might completely overlook.
I suppose if a patient sees Dr. A on a Tuesday in the acute inpatient ward and then follows up with Dr. B in an outpatient clinic 3 weeks later, a rating scale ensures they are both speaking the exact same clinical language.
Spot on. Dr. B knows precisely what Dr. A meant by severe depression because it is tied to a specific metric.
Right, rather than just a subjective adjective jotted down in the notes.
Exactly. That shared language is vital. But the term rating scale is actually a massive umbrella.
It covers a lot of ground, doesn't it?
It really does. It encompasses questionnaires, structured interviews, checklists, and broader outcome assessments. They are used to inform practice, research, and even healthcare administration.
But there is something you have to understand about how these tools evolve, right? Because they don't change like consumer tech.
Oh, no. Think about how we adopt the newest smartphone app. If it's faster, we just use it immediately.
Yeah, we just download the update.
But in psychiatric measurement, adoption is incredibly slow. and deliberately so. New instruments, or shorter self-report versions of old ones, are constantly being proposed in academic journals.
I feel like there's a new scale published every week.
There probably is, but they are adopted at a glacial pace, only as rigorous scientific evidence of their usefulness accumulates over years of clinical trials.
So it's a very conservative field in that regard.
Very. Older measures fall out of favor just as slowly. This isn't about chasing the latest trend in psychology. It is about building a rock-solid scientific consensus.
Okay, let's break down what we are actually tracking here. Because we aren't measuring a physical object like a tumor. The textbook uses a very specific term for this: constructs.
Yes, constructs. Yeah. We don't measure nature directly in psychiatry the way a cardiologist measures blood pressure, or an endocrinologist measures blood glucose.
Right, there's no dial we can just read.
Exactly. We measure constructs.
Yeah.
A construct is a conceptual category. It is an idea we have built to describe a cluster of phenomena.
Like a diagnostic label.
Yes, diagnoses are constructs. The severity of a symptom is a construct. Functional impairment, quality of life, these are all constructs.
And because human experience is inherently messy, these constructs are incredibly complex.
Very messy. So we have to divide them into measurable domains to even begin to track them.
The text differentiates between how we classify these constructs into 3 types: categorical, continuous, and ordinal. Let's make sure we build a clear mental model of this for everyone listening.
Sure, let's go through them.
So categorical classification is basically a binary or a sorting mechanism.
Yeah.
Does this person meet the criteria for major depressive disorder? Yes or no? Which distinct box do they fit into?
It is very black and white.
Right. Then continuous classification measures along a spectrum of intensity or frequency. So how severe is the depression on a sliding scale from 0 to 100?
Exactly. It's a matter of degree.
And then we have the ordinal middle ground, which sort of bridges the two. Ordinal classification uses a finite, ordered set of categories.
It gives us a gradient, but in distinct steps.
Like asking if someone is unaffected, mild, moderate, or severe.
Precisely. Now, what often happens in clinical practice is we use a continuous or ordinal scale, but we apply a strict cutoff score to force a categorical decision.
Give me an example of how that cutoff works on the ward.
Take the mini mental state examination, the MMSE. It is a continuous score up to 30. It tests various cognitive domains like orientation, memory, and attention.
Very standard tool for older adults.
Absolutely. But clinically, a cutoff score below 24 is frequently used as a threshold.
So it forces a decision.
Right. The moment a patient scores a 23, that continuous number triggers a categorical classification. It indicates the potential presence of dementia, which prompts further investigation.
I like to think of this using a weather analogy. Categorical measurement is like looking out the window and asking, is it raining? Yes or no?
I like that.
And continuous measurement is putting a highly sensitive gauge in the garden and asking exactly how many millimeters of rain fell in the last hour.
Which is much more precise.
Right. And the ordinal middle ground is stepping outside and saying, is this a light drizzle, a heavy shower, or a torrential downpour?
That makes perfect sense.
You need entirely different types of measurements depending on whether you're just deciding to carry an umbrella today or if you're planning to build a hydroelectric dam.
That is a great way to put it. But before a clinician can rely on any of these measurements, whether it's an umbrella or a dam, they have to know that the tool itself actually works.
Which brings us to the underlying mechanics, the psychometric engine, as it were.
Yes. Psychometrics, literally translating to mind measuring.
Mind measuring. And the 2 non-negotiable cylinders firing in this engine are reliability and validity.
You cannot have a useful scale without both.
Let's dive into reliability first. Reliability is all about consistency. If we measure the exact same thing twice, do we get the same result? It is the repeatability of the rating.
Exactly. Can we trust the tool to behave the same way every time we use it?
The text outlines 3 standard ways to assess this. First, there is internal consistency. If a scale is measuring depression, every single question should theoretically be pulling in the exact same direction.
Think about what happens if you design a 10-question scale to measure depressive symptoms.
Okay.
9 questions ask about mood, energy, and sleep. But the 10th question accidentally asks about something completely unrelated.
Like what?
Like whether the patient enjoys eating spicy food. That 10th question will not correlate with the others. The internal consistency of the scale immediately drops.
Because it's measuring a totally different construct.
Exactly. This is measured statistically by Cronbach's coefficient alpha, which ranges from 0 to 1. An alpha of 0.70 is generally recommended for evaluating groups in research.
But what if you were in a clinic?
Well, if you are making clinical decisions about an individual patient sitting in your office, the text notes you need a much more stringent alpha of 0.85 or higher. You need to know the tool is rock solid.
So that is the internal plumbing of the test itself. But what about the human element applying the test? Because we aren't machines.
Right. That is where inter-rater reliability and test-retest reliability come in.
Let's define those. Inter-rater reliability measures the agreement between two or more different clinicians evaluating the exact same patient using the same information.
Correct. Do Dr. A and Dr. B come to the same conclusion?
And test-retest reliability measures agreement when the same patient is evaluated by the same clinician at two different points in time.
Yes, but there is a really fascinating quirk here that the chapter points out.
What's that?
Inter-rater reliability usually scores much higher than test-retest reliability.
Wait, hold on. Why is that? You would think the same patient taking the same test would yield the most stable result compared to two different doctors arguing over a diagnosis.
You would think so, but it comes down to the volatility of the human condition. When you test a patient at two different times, their actual state might have changed.
Oh, I see.
Their mood fluctuates. They might have slept poorly the night before the second test. The room conditions might be different.
The underlying reality has shifted.
Exactly. The classic example in the textbook is state anxiety. State anxiety is your anxiety right now, in this specific fleeting moment.
Like right before public speaking.
Right. It fluctuates so rapidly that true test-retest reliability is virtually impossible to measure accurately. The test might be perfectly consistent, but the underlying construct itself is constantly moving.
As you say, you can't blame the thermometer if the temperature actually dropped.
That is exactly it.
That makes a lot of sense. So how do we actually calculate this agreement mathematically?
For continuous constructs, like a severity score on a spectrum, we measure agreement using the intraclass correlation coefficient, or ICC.
Okay, ICC for continuous.
And for categorical constructs, like two registrars deciding yes or no on a schizophrenia diagnosis, we use the kappa coefficient.
And what's a good score?
A general rule of thumb is that an ICC or kappa above 0.8 is considered excellent clinical agreement.
Okay, so that is reliability. The tool is consistent. But here is where we hit a massive philosophical wall. The paradox of validity.
It's my favorite paradox in psychometrics.
You can have a highly reliable scale that is completely invalid. Let me use an analogy. Imagine a bathroom scale that has a broken spring.
Yeah.
Every time you step on it, it says you weigh exactly 500 kilos. If you step on it 10 times in a row, it says 500 kilos every single time.
Right, so it's perfectly reliable.
Exactly. It has perfect reliability. It is entirely consistent, but it has absolutely zero validity because it is not telling you the truth about nature. You do not weigh 500 kilos.
That perfectly illustrates the point. Validity is fundamentally about accuracy. Does the score represent the true state of affairs?
And in psychiatry, establishing validity is incredibly difficult because for many constructs, there is no absolute underlying biological truth.
None at all. There is no blood test for borderline personality disorder. You cannot biopsy a manic episode. Right. So we have to triangulate validity from a few different angles to make sure we aren't just measuring our own biases.
Let's go through those angles. We start with face validity and content validity. Face validity is simply whether the items appear to assess the construct in question.
Right. Does this questionnaire look like a depression test to a layperson?
But the text highlights a really surprising clinical trap here. High face validity can actually be a massive disadvantage.
It absolutely can, particularly in forensic or addiction psychiatry.
Why is that?
Well, if you are trying to measure socially undesirable traits like substance abuse, malingering, or antisocial personality traits items with a transparent, obvious relationship to the construct, allow the patient to easily hide the truth.
So if your questionnaire simply asks, do you frequently lie to manipulate others for personal gain?
The face validity is exceptionally high, but the clinical utility is zero.
Because no one is going to say yes to that.
Exactly.
No.
A patient with severe antisocial traits who wants to present well to a parole board will just tick no.
Right.
A good test for these constructs often needs low face validity. You need questions that seem innocuous on the surface, but statistically predict the undesirable trait behind the scenes.
That is fascinating. Moving beyond face validity, we have criterion validity. This is when you compare your new rating scale to an established gold standard.
Right.
But you just said we don't have blood tests, so what on earth is the gold standard in psychiatry?
The textbook notes that for diagnostic interviews, the universally accepted gold standard is the lead standard. LEAD.
And what does that stand for?
It stands for longitudinal, expert, all data.
Longitudinal, expert, all data.
Okay, the ultimate truth isn't a single questionnaire. It is an expert clinical evaluation conducted over time.
So it's not a quick snapshot.
No, it incorporates medical records, informant interviews from family, laboratory results to rule out medical causes, and longitudinal observation of how the illness actually progresses over months or years.
I see. So you validate a new, say, 10-minute rapid screener by seeing how well it matches the outcome of that exhaustive lead standard. But what happens when there is no gold standard at all? Say we are looking at a completely newly proposed syndrome that isn't in the DSM yet.
That is where construct validity comes in. You have to compare the measure to external validators. This concept was famously described by psychologists Cronbach and Meal as the nomological net.
The nomological net sounds very sci-fi.
It does, but practically, you look at external factors that should logically correlate with your diagnosis.
Give me an example of that.
For example, if you have developed a purportedly valid measure for bipolar mania, you would expect the individuals identified by your new measure to have a higher family history of mood disorders.
Because we know mania is highly heritable.
Exactly. You would also expect them to show a good clinical response to mood stabilizers like lithium. You validate the scale by looking at the course of the illness and the treatment response.
So if your new mania scale identifies people who don't respond to lithium and have zero family history, your scale probably isn't measuring true mania.
Spot on. It's probably measuring severe ADHD or something else entirely.
Let's talk about the actual maths of clinical decision-making. We have built a reliable and valid tool. The next challenge is deciding where to draw the line.
The cutoff score.
Right. If you are using a continuous scale to make a categorical diagnosis, you have to establish a cutoff. And that introduces the massive tension between sensitivity and specificity.
This is the daily struggle for scale designers.
Let's define them. Sensitivity is your true positive rate. It is the test's ability to catch everyone who actually has the disease. Specificity is your true negative rate. It is the test's ability to correctly filter out everyone who doesn't have the disease.
They exist on a seesaw. You usually can't maximize both.
Right. So if you lower the diagnostic threshold, say, you decide that only a very mild occasional feeling of worry is required for a diagnosis of generalized anxiety disorder, you heavily increase your sensitivity.
You will catch almost every true case of anxiety out there.
But your specificity plummets. You will generate a mountain of false positives, diagnosing people who are just experiencing normal, healthy, daily stress.
And potentially medicating them unnecessarily.
Yeah, exactly. But if you raise the threshold to filter out those false positives, demanding severe daily panic attacks for a diagnosis, your specificity goes up. You are only catching severe pathology.
But your sensitivity drops.
Right. Meaning you will inevitably miss true cases of moderate anxiety.
The clinician and the scale designer constantly have to ask, what are the real-world consequences of a false positive versus a false negative in this specific scenario?
Let's walk through an epidemiological maths example because the text really highlights how this plays out with predictive value.
This is where the maths gets really sobering.
Imagine you are screening for a very rare condition, say a specific obscure psychotic disorder that only affects 1 in 10,000 people in the general population.
It's very low prevalence.
You build a scale with an incredible 99% specificity. That sounds great, right?
That sounds phenomenal.
But because the prevalence is so incredibly low, if you test 10,000 people, you will find the one true case. But with a 1% false positive rate from that 99% specificity, you will also falsely diagnose 100 perfectly healthy people. Wow.
So out of 101 positive results on your test, 100 are completely wrong. Your positive predictive value is less than 1%.
The mathematics of the scale always have to be interpreted through the epidemiology of the population you are testing.
Context is everything.
It is. A screening tool that works brilliantly in a high prevalence setting, like an acute psychiatric ward, might be mathematically useless and actually harmful in a primary care waiting room.
But what happens when the patient's reality completely breaks down? All these theoretical psychometrics are fascinating, but we need to see how they operate in the mud and the blood of actual clinical practice.
It's time to look at the real tools.
Exactly. We have built our cartographer's tools. Now let's look at the actual maps. The text organizes these into several categories, starting with broad functioning and screening.
When we talk about broad functioning, a prime example is the WHOD's 2.0, the World Health Organization Disability Assessment Schedule.
I know for a long time, Psychiatry relied on something called the GAF, the Global Assessment of Functioning Scale. Yes, from the old DSM-IV. It was a single number from 0 to 100.
Why did we move away from that?
The DSM-5 discarded the GAF because a single number conflated symptom severity with functional impairment. It was too blunt an instrument.
Can you give an example?
You could have a patient with severe auditory hallucinations who, nonetheless, somehow managed to keep a job and pay their bills. The GAF couldn't handle that nuance. It didn't know how to score severe symptoms but high functioning.
So the WH-8 has replaced it to fix that?
Yes. The WH-8 assesses disability across 6 domains: understanding and communicating, getting around, self-care, getting along with people, life activities, and participation in society.
So it's purely focused on functional impairment, entirely irrespective of the specific psychiatric diagnosis.
Exactly. It doesn't care if you have depression or schizophrenia.
Yeah.
It just asks, how well are you navigating your life?
Another massive one in this broad category is the SF-36, the short form 36. What I find incredibly useful about the SF-36 is that it is completely independent of specific diseases.
It's ubiquitous in medicine.
Yeah, it's used widely in general medicine, cardiology, rheumatology, as well as psychiatry. This gives it a really unique clinical utility.
How so?
You can use it to directly compare the health outcome and functional burden of a psychiatric patient, say someone with severe panic disorder, directly against a medical patient, like someone with congestive heart failure.
I see.
It proves, with objective data, the profound disabling effect of psychiatric illness. It forces the wider medical community to recognize that mental illness is just as functionally debilitating as physical illness.
It bridges the gap between physical and mental health domains beautifully. It provides hard proof for parity of esteem.
The text also highlights the DSM-5 cross-cutting symptom measures.
Yes, the APA introduced these to catch symptoms that blur traditional diagnostic boxes.
Because, let's face it, patients rarely read the textbook.
They certainly don't. They do not present with symptoms neatly confined to just one DSM category.
So how does the cross-cutting measure work?
The adult level 1 forms screens across 13 broad domains, and the protocol is quite sensitive. If a patient scores a 2, which indicates just mild symptoms on almost any domain, it triggers a deeper level 2 evaluation.
Just a 2 triggers a full workup.
Yes. It is designed to ensure that secondary symptoms like mild dissociation in a patient presenting primarily for depression are not missed in the initial rush of an assessment.
Which perfectly sets up the next major evolution discussed in the chapter, the dimensional revolution.
This is where the field is truly heading.
Modern psychiatry is increasingly recognizing that strict, discrete, categorical boxes like you either have PTSD or you do not capture the reality of mental illness. Pathology blends.
It bleeds across the borders all the time.
The text outlines a massive shift toward a hierarchical dimensional model. And the premier tool they highlight here is the spectra, the indices of psychopathology.
The spectra represents a true paradigm shift in how we think. It moves us aggressively away from categorical thinking.
What does it actually look like?
It's a 96-item tool that assesses 12 lower-order clinical constructs, things like depression, anxiety, severe aggression, and paranoid ideation.
Okay, 12 constructs.
But based on decades of multivariate statistical research, it feeds those 12 constructs into 3 higher-order spectra. These are internalizing, externalizing, and reality impairing.
Internalizing, externalizing, and reality impairing.
Exactly. And those 3 spectra then mathematically aggregate into a single overarching metric called the General Psychopathology Index, or the GPI.
I've heard this referred to in research as the P factor.
Yes, the P factor, a single mathematical marker of overall psychiatric complexity and burden.
Like a G factor for general intelligence, but for psychopathology. That is incredible.
It really is. It captures the sheer weight of the illness.
But let's ground this in reality for a second. If the spectra takes 15 to 20 minutes to complete, and it maps everything from social anxiety to grandiosity to substance use, all while giving you a P factor burden score.
I know where you're going with this.
Why do we need anything else? Why not just hand every single patient the spectra clipboard in the waiting room and be done with it?
Because of cognitive and emotional resources, the text explicitly warns about this exact scenario.
Right.
A broadband measure like the spectra is comprehensive, yes, but it can be incredibly taxing on the patient.
Imagine you have a patient in an acute setting, someone experiencing active psychosis, severe agitation, or profound depressive psychomotor retardation where moving or thinking feels like moving through wet concrete.
Exactly. Handing them a 96-item questionnaire is practically useless and, frankly, clinically inappropriate.
You just won't get valid data.
They will either refuse entirely, randomly tick boxes just to make you go away, or become deeply frustrated and distressed. In those acute settings, you need targeted, clinician-administered tools.
Which brings us perfectly to the assessment of psychotic disorders.
Yeah.
This is where subjective self-report completely breaks down.
It shatters entirely.
The core issue here is what clinicians call the insight problem. How do you use a rating scale on a patient who fundamentally lacks insight into their condition?
You generally can't, not a self-report one.
By definition, if someone is experiencing a delusion, say they firmly believe the television is broadcasting their private thoughts, they believe it is reality. They cannot rate the unreality of their own delusion on a scale of 1 to 5.
Exactly the problem. For psychotic disorders, self-report is wildly insufficient. Observation absolutely must be combined with a structured clinical interview.
The text contrasts two major historical tools here. First is the BPRS, the brief psychiatric rating scale.
Yes, developed in the 1960s. It is a broad 18-item scale that relies heavily on clinician observation. It assesses things like somatic concern, anxiety, conceptual disorganization, and grandiosity.
It's still used?
It is excellent for historical comparison because it has been used in decades of classic schizophrenia trials.
Yeah.
But in modern research, it has largely been supplanted by the PAN-SS.
The positive and negative syndrome scale. Let's unpack the PAN-SS. What was the older BPRS missing that necessitated this new tool?
The PAN-SS adopted a crucial clinical distinction that revolutionized modern schizophrenia research: the absolute separation of positive and negative symptoms.
Let's define those for the listeners. Positive symptoms are pathological excesses, right?
Yes. They are things added to the patient's normal reality. Auditory hallucinations, bizarre delusions, severe conceptual disorganization.
And negative symptoms are pathological deficits.
Exactly. They are normal human functions taken away. Affective flattening, which is a lack of emotional expression. Alogia, or poverty of speech. Avolition, a lack of drive. And profound social withdrawal.
Give me a brief case study of how a clinician uses the PAN-SS to track a change in a patient over time on the ward.
Sure. Imagine a 22-year-old male admitted with a first episode psychosis. He is experiencing terrifying auditory hallucinations and believes the government is tracking him.
So, very high positive symptoms.
Right. But he's also speaking in a flat, monotone voice. His face is completely blank, and he sits in his room staring at the wall all day.
High negative symptoms.
Exactly.
Yeah.
The PAN-SS has entirely separate subscales for positive symptoms, negative symptoms, and general psychopathology. Let's say we start him on a first-generation antipsychotic medication.
Okay.
4 weeks later, we re-administer the PAN-SS. The scale might show that his positive symptom score has dropped dramatically. The voices have stopped, the delusions have faded.
That sounds like a success.
But his negative symptom score might have actually worsened. The medication might be sedating him further, heavily increasing his emotional blunting and withdrawal.
Ah, I see.
The PAN-SS allows the clinician to see this divergence clearly. Tools like the PAN-SS, or the SAPS and SANS, the scale for the assessment of positive symptoms and the scale for the assessment of negative symptoms provide a high-resolution map that allows us to separate these entirely different dimensions of the illness.
That distinction is so critical for guiding pharmacological treatment because you might need to adjust the dose or switch meds if the negative symptoms are worsening.
Precisely. It changes the management plan.
Let's shift from psychosis to depressive and bipolar disorders. When we look at depression, the absolute granddaddy of all rating scales is the HAM-D, the Hamilton Rating Scale for depression.
It's everywhere in the literature.
Also developed around 1960 and heavily used in almost every major antidepressant trial, but the text points out a really famous and frankly quite dangerous blind spot in the HAM-D.
The HAM-D is very much a product of its time. Max Hamilton developed it by studying severe inpatients in the mid-20th century.
Which sees the data.
Heavily. Because of that, it focuses very heavily on the somatic, physical symptoms of melancholic depression. Things like profound insomnia, significant weight loss, and psychomotor agitation.
But as our understanding of depression evolved with later editions of the DSM, psychiatry recognized what we call reverse neurovegetative signs.
Yes, these are incredibly common in a subtype called atypical depression.
So instead of not sleeping, the patient exhibits hypersomnia, sleeping 14 or 15 hours a day. Instead of losing their appetite and losing weight, they exhibit hyperphagia.
Eating constantly, craving carbohydrates, and gaining significant weight.
And here is the massive clinical trap. The classic 17-item A-sham-D does not score these reverse signs.
It doesn't even look for them.
Meaning, you could have a patient sitting in front of you with profound, debilitating atypical depression, sleeping their life away, but because they aren't losing weight or suffering from insomnia, they might actually score artificially low on the CAM-D severity scale.
Is a massive caveat. You could look at the score on paper and think, oh, they're only mildly depressed, when in reality the tool is just blind to their specific phenotype of suffering.
So what do we use instead?
The text notes that newer scales, like the IDS, the Inventory of Depressive Symptomatology, map much better onto modern DSM-5 criteria. They deliberately catch those reverse signs.
What about for clinical trials?
For trials, you often see the MADRs, the Montgomery-Åsberg Depression Rating Scale, which was designed explicitly to be highly sensitive to very small changes in established depression over time.
But what about bipolar disorder? Assessing mania seems to carry its own...
If you just hand them a current symptom checklist, they look exactly like a classic case of unipolar depression.
And that's dangerous.
Very dangerous. If you prescribe an antidepressant without a mood stabilizer in that scenario, you risk triggering a severe manic episode.
So how do you get the real history?
You have to conduct a careful retrospective analysis via interview, and often you absolutely require informant data from spouses or family members to get an accurate history of past manic episodes.
Because the patient's own recall of the mania might just be, I had a really productive summer.
Exactly. The spouse remembers the bank account being emptied. The patient just remembers feeling great.
The necessity of informant data really changes the dynamic of an assessment. Let's look at a few of the specialized domains where standard self-report needs a lot of scaffolding.
There are quite a few tricky domains.
Let's start with obsessive-compulsive disorder. The gold standard mentioned in the text is the YBOCS, the Yale-Brown Obsessive-Compulsive Scale.
A brilliantly designed tool.
What's deeply clever about the YBOCS is how it separates the internal pathology from the external behavior. It separates the obsessions, the intrusive, terrifying thoughts, from the compulsions, the repetitive, ritualistic behaviors.
And crucially, it doesn't just ask what the obsessions are.
Right. The content almost doesn't matter as much as the impact.
Exactly. It measures the time consumed by them, the distress they cause, the patient's feeling of control, and their ability to resist them. It quantifies the functional burden of the rituals.
Moving to substance use disorders, the textbook contrasts two very different types of tools, the DAST and the ASI.
These serve two entirely different clinical masters.
The DAST, the Drug Abuse Screening Test, is brilliant for a quick primary care screen. It's a brief self-report that looks at lifetime drug use. It asks questions like, have you ever had a problem with your drug use? Or, have you ever neglected your family because of drug use?
It's very quick, very efficient.
But because it measures lifetime use, your score will never, ever go down. Once you have neglected your family in the past, that box is permanently ticked.
Which means the DAST is entirely unhelpful as an outcome measure if you are trying to track a patient's active recovery over a 6-month treatment program.
For tracking active recovery, you need something like the ASI, the Addiction Severity Index. The ASI is an absolute behemoth.
It really is. It's massive.
It's 142 items covering medical status, legal issues, employment, family relations, and psychiatric status over the past 30 days. It provides a holistic, high-definition picture of how the addiction is impacting every single facet of the patient's life right now.
But let's be real about the limitations here.
Yeah, the time factor.
It takes up to 75 minutes to administer.
75 minutes.
If someone is sitting in an addiction clinic, potentially in the early stages of withdrawal, feeling absolutely miserable, and you sit them down for a 75-minute, 142-question interrogation.
You're not getting valid data.
You are not. You are getting a very justified hostile response, or they'll just walk out.
That is the harsh reality of clinical pragmatics. You have to balance the depth of the data with the tolerance of the patient.
We see similar challenges in eating disorders. The text highlights the EDE, the Eating Disorders Examination.
Why does that one stand out?
Because of the intense secrecy, profound shame, and frequent lack of insight, often surrounding disorders like anorexia nervosa, the EDE requires a trained clinician to conduct a semi-structured interview.
So self-report questionnaires just aren't trusted here?
Generally, no. And the text notes a crucial point. In eating disorders, you often have to rely heavily on validation against objective biological markers.
Like what?
You need serial body weight measurements. For bulimia nervosa, you might need a dental exam to look for enamel erosion from chronic purging. The subjective self-report is often deliberately obscured by the pathology itself.
The illness forces them to hide the symptoms.
Exactly.
We see that same reliance on external observation in cognitive disorders and dementia. The MMSE, which we discussed earlier, is a classic brief screen. But to truly stage the severity of dementia, the text mentions the CDR, the Clinical Dementia Rating Scale.
Right, which stages impairment from 0 to 5, heavily weighting memory loss and orientation.
But the most fascinating tool in this domain, I think, is the NPI, the Neuropsychiatric Inventory. Because the NPI doesn't interview the patient at all.
It interviews the caregiver, the informant.
Why is that so critical?
The NPI asks the caregiver about the patient's non-cognitive symptoms, delusions, hallucinations, severe agitation, apathy, and disruptive nocturnal behaviors.
The behavioral stuff.
Yes. If a patient with severe Alzheimer's is pacing the halls at 3 a.m. shouting at unseen intruders, they cannot accurately report that to you the next morning. They won't remember.
And crucially, the NPI also measures the distress those specific behaviors are causing the caregiver.
That is perhaps the most important part, because clinically, caregiver burnout is often the primary driver for a family finally seeking nursing home placement. Measuring the caregiver's distress is just as vital as measuring the patient's agitation.
So we have covered the need for standardization, the deep psychometrics of reliability and validity, the dimensional revolution of the spectra, and the specific tools from psychosis to dementia.
We've covered a lot of ground.
Let's pull all the way back. Let's look at integration and clinical reasoning. We have all this data. We have folders full of numbers, Likert scales, and continuous variables.
A mountain of paperwork.
Exactly. What does this all mean for the clinician actually sitting across the room from a suffering human being?
It means the clinician has to become an expert synthesizer of information. The first step is navigating what we can call the source of information matrix.
Which means constantly evaluating who is generating the data.
Precisely. Self-report tools are fantastic and generally the most valid for internal states, depression, anxiety, subjective distress. No one knows a patient's internal sadness better than the patient themselves.
But as we've seen with psychosis and eating disorders, self-report is terrible when insight is compromised.
Informant spouses, parents, nurses, caregivers become absolutely mandatory when you are dealing with conditions involving limited insight, like dementia or acute mania.
Or when dealing with social undesirability.
Right, like antisocial personality traits or severe substance use, where the patient is heavily incentivized to minimize the problem to avoid legal or social consequences.
And of course, when the patient has limited recall capacity, such as a patient in acute delirium or a very young child.
The art of psychiatry is triangulating the self-report, the informant report, and your own trained clinical observation.
And then there is the elephant in the room. Time, the cold, hard pragmatics of clinical practice. The textbook does not shy away from this limitation at all.
What's the biggest barrier we face?
We joked about the 142-item ASI taking 75 minutes. The full clinical dementia rating protocol takes over an hour. In a busy public health clinic or an understaffed acute inpatient ward, you just do not have that kind of time.
You really don't. And that is the ultimate clinical calculus every practitioner must perform.
How does the text frame that?
It frames it perfectly. A clinician must constantly ask, does this formal tool contribute useful information in an efficient manner that outweighs just talking to the patient?
If an instrument takes 45 minutes to administer, but yields information you could have gathered in a 10-minute targeted clinical interview,
then it is not clinically useful in that setting. It belongs in a research trial, not a busy ward.
These rating scales are aids to understanding. They establish a shared vocabulary so that researchers discovering new treatments can communicate effectively with the clinicians applying those treatments.
But they are not replacements for clinical judgment.
The numbers serve the clinical narrative. They do not overwrite it. The map is not the territory, but you still need the compass.
I couldn't agree more.
Okay, let's crystallize everything we've covered. We're going to distill the absolute core insights from this deep dive into 5 key takeaways.
Sounds good.
Number 1. Psychiatric rating scales transform subjective human suffering into structured, measurable data. This allows for vital standardization across different clinicians, services, and research studies, and establishes a baseline to objectively monitor whether a treatment is actually working over time.
Number 2. The psychometric engine of any useful scale relies on 2 core properties: reliability, which is the consistency and repeatability of the measure, and validity, which is its accuracy or conformity to truth. A scale can be perfectly reliable without being valid, but a scale must be valid to be clinically useful.
Number 3, different clinical scenarios demand entirely different measurement architectures. You use a brief screener like the PHQ for primary care, a historical tracking tool reliant on observation like the BPRS for longitudinal psychosis studies, a deep dimensional analysis like the spectra for complex psychopathology, or a purely functional measure like the WDOTAs to assess disability independent of any diagnosis.
Number 4, the source of the information matters immensely. Clinicians must know when a patient is a reliable narrator for their own internal states, and when an informant, like a spouse or caregiver, is mandatory due to impaired insight, such as in mania, dementia, or severe substance use.
And number 5, the golden rule of the chapter. Quantitative measures complement, but never replace, clinical judgment. A score can indicate symptom severity, but it cannot fully capture an individual's context, strengths, or lived experience. Numbers serve understanding, not the other way around.
Let's move into our learning reinforcement. We've prepared 5 single best answer style questions to test the application of these concepts.
Right. For the clinicians and students listening, I will pose the question, I'll give you a second to think about the answer, and then we will break down the reasoning.
Ready when you are.
All right, question 1 focuses on psychometric concepts. A research team is developing a new self-report screening tool for antisocial personality traits for use in a forensic setting. During the review process, critics note that the tool has very high face validity. Why might high face validity actually be a disadvantage for this specific instrument? Take a second to think about that.
This is a classic trap in scale design.
What's the answer?
The answer is that high face validity is a disadvantage here because items with a transparent, obvious relationship to socially undesirable traits easily allow patients to hide the truth or malinger. If the questions make it obvious that the test is looking for antisocial or criminal behavior, a patient motivated to conceal those traits will simply answer dishonestly, rendering the test clinically invalid.
Right, you can't just ask a criminal if they plan to commit more crimes. Question 2, looking at mechanisms. A clinical trial is tracking continuous changes in depression severity over a 6-week period using a 0 to 100 scale. The researchers want to ensure that the 2 different psychiatrists rating the patients are scoring them consistently based on the same clinical interviews. Which statistical measure is most appropriate to evaluate the inter-rater reliability of this continuous construct? Think about the type of data here.
Remember the difference between categorical and continuous maths.
It's the right measure.
The correct statistical measure is the intra-class correlation coefficient, or ICC. The ICC is specifically used to measure inter-rater and test-retest reliability for continuous constructs like a severity score on a wide spectrum. The kappa coefficient, on the other hand, is used for categorical data, such as 2 clinicians agreeing on a simple yes or no diagnosis.
Excellent. Question 3 is about clinical reasoning. A clinician is assessing a 24-year-old patient in the emergency department for a suspected first episode psychotic disorder. The patient is highly agitated, responding to internal stimuli, and clearly lacks insight into their condition, believing the nursing staff are government agents. Why is a self-report symptom questionnaire inappropriate in this scenario, and what type of rating scale is required? Consider the insight problem.
This is a crucial daily reality on the acute ward.
Why shouldn't we use self-report here?
A self-report measure is inappropriate because a patient lacking insight cannot accurately report on the severity or unreality of their own delusions or hallucinations. In this scenario, scales requiring observational data by a trained clinician, such as the PAN-SS or the BPRS, are absolutely required. You need an instrument that allows the clinician to integrate the patient's verbal output with their own objective behavioral observations.
Right, you have to interpret what you are seeing. Question 4, back to concepts. You are tracking an outpatient's depression over several months. The patient presents primarily with reverse neurovegetative signs, specifically hypersomnia, sleeping up to 14 hours a day, and hyperphagia, significant carbohydrate craving and weight gain. Which classic psychiatric rating scale might fail to capture the specific severity accurately? Think back to the 1960s.
A very famous blind spot.
Which scale is it?
The classic scale that might miss this is the AMD, the Hamilton Rating Scale for Depression. The standard 17-item AMD is heavily weighted towards traditional melancholic somatic symptoms, like insomnia and weight loss. It lacks specific items to score the reverse signs of hypersomnia and hyperphagia, meaning a patient with severe atypical depression might artificially score much lower on this specific instrument.
Perfect. And our final question, question 5, testing clinical reasoning. Y is a screening tool like the DAST, the drug abuse screening test, highly useful in an initial primary care evaluation, but entirely unhelpful as an outcome measure in a 6-month clinical trial for addiction treatment. Think about what the DAST actually measures over time.
This goes back to choosing the right tool for the job.
Why is the DAST unhelpful here?
The DAST is unhelpful as an outcome measure because it focuses on lifetime drug use. It is a fantastic historical screener to identify if a problem has ever existed. But because it measures the historical presence of an issue, a patient's score will never decrease to reflect recent recovery, abstinence, or short-term treatment effects over a 6-month trial. For tracking recent change in current status, a tool assessing recent severity, like the Addiction Severity Index, is required.
For a much deeper look at the psychometric maths, the nuanced differences between these instruments, and the full list of scales, be sure to read alongside Chapter 7.8 in Kaplan and Sadok's comprehensive textbook of psychiatry.
It really is essential reading for anyone looking to truly understand the evidence base beneath our clinical decisions.
Before we wrap up, I want to leave you with a final provocative thought that builds on everything we have discussed today.
Go ahead.
We have talked a lot about paper questionnaires, clinician observations, and informant interviews. But as we move further into the digital age, psychiatry is seeing the rapid rise of something called digital phenotyping.
A massive new frontier.
Right. This is the use of smartphone data, your typing speed, your GPS mobility patterns, the fluctuations in the pitch and tone of your voice during phone calls as passive, continuous rating scales. The phone acts as a constant, objective observer.
Always collecting data.
If the entire goal of the cartographer's toolkit is to track the invisible, subjective landscape of the mind, what happens when our phones become the ultimate informants? What does the clinical landscape look like when our devices are measuring our mental state 24 hours a day without ever having to ask us a single question?
It's both incredible and slightly terrifying.
Here are the details of this episode.
Psychiatric rating scales. Byline. What cannot be measured cannot be tracked. But what is measured must still be understood.